So my case about septic shock with echocardiography full management or changed decision depending on the echo findings started with a patient who was an elderly man. I'll give you all the history about him, but I just need to go through some physiological principles before I present the case. After case presentation, I'll give you the mic or the whiteboard to write your questions. After that, I will answer all the questions. Then we will go to basic echocardiographic views in the ICU, like in the term of point of care ultrasound. After we finish point of care ultrasound orientation, I'll give you the mic and we'll open all the mics and chat what to do next, what you think is the best way to help others to learn this new science. So before we start, I need you to be aware with Frank-Starling law. Frank-Starling law, the more end diastolic volume as you see, the more stroke volume. Till certain point, there is increase in end diastolic volume, but no much increase in the stroke volume. So B, this is a fluid responder or a patient who responds by increase in the stroke volume and cardiac output when you give him fluids, while in the stage A, there is no much change in the stroke volume if you give more fluids or you increase his end diastolic volume. And the last point, when you give more fluids and actually stroke volume started to decrease again, so you are doing harm by giving IV fluids. So the more fluids you give here, there is decrease in the stroke volume because of heart failure. The optimum muscle length is this area. This is the maximum contractility of the heart with the maximum response of stroke volume. Anything below or after this optimum muscle length will be towards low cardiac output or lower cardiac output. This is the first fact, and it should be crystal clear in our mind. Here, this is the Frank-Starling law in 4 different curves, and the difference between those curves is the state of contractility of the heart. So here is the normal. So sorry, this is the normal. If you push the contractility like in exercise, you are pushing the curve higher. So with the same end diastolic volume here, with the same end diastolic volume, you get more ventricular performance and more cardiac output. If you are pushing the heart towards heart failure or fatal myocardial depression, in this occasion with the same volume, because of low contractility, the ventricular performance is low or lower, and hence the cardiac output is lower. This fact should be crystal clear in your mind. So I can control the cardiac output by heart rate, stroke volume, contractility, and many other items in this diagram. I'll discuss it. Mean blood pressure depends not only on the cardiac output, but also on the stroke in the systemic vascular resistance. So this is the most important equation in shock management. Mean arterial blood pressure equals cardiac output multiplied by systemic vascular resistance. So here, this is the cardiac output, which is heart rate and stroke volume. Stroke volume depends on the venous return and myocardial functions, systemic activity, like if you are giving epinephrine or norepinephrine, you are pushing more venous blood to the heart, so increasing the stroke volume. The same idea of Starling law. And the heart rate, the more the heart rate, the more the cardiac output, but within limits. So if you are tachycardic and your stroke volume kept constant, that means higher cardiac output. But the problem when you are tachycardic and lower end diastolic time allows for lower end diastolic volume, so your stroke volume is getting lower. I have no clue in the clinical life to tell me which heart rate is really affecting my stroke volume or my end diastolic volume. If I know the cardiac output, or I can calculate the cardiac output by any mean, like the Swan-Ganz catheter or whatever, and I have the mean arterial blood pressure from an arterial line, so you can have an idea or calculate the systemic vascular resistance. That's fact number two. And the fact number three, which is the new era now of all septic shock management, which is heart failure with a preserved ejection fraction, or diastolic heart failure, the old terminology. So here, this is endodiastole, or this is diastole, and this is isovolumetric contraction phase, then systole, then isovolumetric contraction phase. Here, this is end systolic volume and end diastolic volume. As you see in this one, if the volume pressure is normal, so you can accommodate more blood volume without increasing the pressure. While if your diastolic function are impaired, so the pressure change in the same volume is higher. So if my end systolic volume is 75 milliliter here in this area, it should give me very low left ventricular end diastolic pressure. If this pressure increase, that means diastolic dysfunction, and it will tolerate in the same pressure a lower end diastolic volume. So it's a volume pressure relationship. So I have no clue clinically to assess this relationship. How I know if my patient has a diastolic dysfunction or no clinically? You can know that only after the patient develops pulmonary edema after a fluid bolus, which is too late. You flooded the lung, extravascular lung water is increased, and the only way to take that out is by diuretics, which is nephrotoxic medications. So let's go to this curve, which really makes a great change in our understanding to septic shock. This is the normal diastolic functions. So the first E wave, this is the early, that's why E, atrial filling, which presents 60 to 75% of the left ventricular filling from the left atrium. While the A wave is the atrial kick or atrial contraction, which represents 25 to around 35–40% of the ventricular filling. If this is reversed, that's the first grade of diastolic dysfunction, or the mild diastolic dysfunction, or the impaired relaxation. The problem with EA ratio, it causes pseudo-normal in grade 2 diastolic dysfunction, which have severely impaired left ventricular relaxation, and the compliance is very low, so the left atrial pressure is very high, which will be reflected on the lungs. And this is the time our lungs started to be flooded with water and the extravascular lung water increase. And again, there is no clinical clue to judge that. And severe diastolic dysfunction or the restrictive, you see E and A are again the same as normal, but higher EA ratio. So the normal EA ratio is up to 2. Here, it is again more than 2 with different variables. We can see that in the echo in a while. Let's go now to my case presentation. What happened with my case? First of all, before I proceed to the next step, is everybody clear with those physiological principles? I'll open the mics for any questions in this moment. Dr. Islam, are there any questions or anything unclear about those ones?
It's okay.
Dr. Musaiba, is there anything unclear about those physiological principles?
According to the EA ratio بتاعت المودريت diastolic dysfunction يعني مش فاهمة الفرق ما بينها وما بين النورمال يعني المودريت.
Yeah, that's a very good question, and we cannot differentiate the difference between normal and pseudo-normal from the EA ratio that I showed you. I show you the difference between EA ratio in different modality of echo during the case presentation. Tariq,
Yes.
are you okay
Yes,
with
it's
all
okay.
those? I'm really sorry, I don't know what's the level of everyone. Maybe a few of you or maybe all of you are more senior to me, but I just need to be all on the same page during this discussion. So everybody's clear about these physiological principles?
Yeah.
Good. So I'm putting your mics off for the moment and we'll continue our discussion. So the background is septic shock is on top of the highest causes of mortality and morbidity. Recent studies have highlighted complex cardiovascular system involvement in the septic shock. Diastolic dysfunction or heart failure, the new terminology is heart failure with a preserved ejection fraction, is correlated with high mortality in patients with septic shock. And as I have few review articles and case studies on this webinar, I'll give it to you. It's already uploaded there. So at the end, and we'll discuss it at the end of this session, but you need to know that this is a fact. Heart failure with a preserved ejection fraction shows high mortality with septic shock, while there is no clinical clue to discover that. Even with the Swan-Ganz catheter or the old modalities, we can have an idea about systolic but not diastolic functions. Diastolic function could emerge from the sepsis itself or from the vasopressors, or sometimes, like in my case, it was from the inotrope. So you are using the inotrope or the adrenaline as an inotropic agent, while actually, because it shortens the diastolic time, so it worsens diastolic function, and you do harm, while you think that the dobutamine or the adrenaline you are putting is improving the condition, because you cannot measure that without the echo. That's my belief anyway. Fluids. Every patient with shock is entitled to one of three, either fluids, pressors, or inotropes. But the clinical question is how much to give fluids and when to start it, and is the time I'm starting my fluid crucial? I mean, should I delay it or I start it early? We'll see that in my case now. And when to stop. So is it just 500 or 2 liters or 3 liters? When is the cutoff to stop? That's another challenge, and it should be always tailored according to variable patient needs. So echocardiography is considered a growing tool as a non-invasive bedside, radiation-free, easily repeatable, you can follow the trend, tool used in hemodynamic assessment in critical care settings. My case was a 70-year-old man presented with septic shock. It was an initially wrong diagnosis of contained AAA rupture, but this has nothing to do with our case scenario, so I just neglected this part of discussion. Due to bowel ischemia, so the patient admitted to OR for emergency laparotomy. They found peritonitis. The patient is previously totally healthy, had no hypertension, no diabetes, no other comorbidities, never cardiac patient. Open laparotomy, they found that severe mucosal ischemia. They did the bowel resection, so it was a bloodless operation or almost a bloodless operation, and patient had at that time 8.5 lactic acidosis. Aggressive resuscitation was started from ER during his OR stay because it was bloodless surgery, so they didn't transfuse him any blood, but the patient hemodynamics were like deteriorating all the time. So they initially started with phenylephrine, escalated that to noradrenaline, and when noradrenaline is failing to control that, they reached 30 mics of noradrenaline. Then they started to add adrenaline, and they given some bicarb. All that failed to control his blood pressure. Then at the end of surgery, patient was shifted to the ICU. I received him like 12 midnight or half 12 midnight, just after midnight. And at this time, his blood pressure was 100/60. He's on noradrenaline of 30 mics, adrenaline of 20 mics, and he's anuric for good time, like 3 hours. The question in this case, shall I give more fluids? He received 3 liters, almost 3 liters of crystalloids and colloids. plus what he received in emergency room, like 1.5 liters? What's the fluid deficit? Is he fluid responder or not? Or shall I go with NORAD or adrenaline change? And now I'm giving you back the mic to tell me, what do you think? Islam, what you are going to do with this patient if
usually
you
we depend on CVB. We usually depend on CVB to assess the volume status of the patient. We don't have echo to assess.
Okay, so do you know, Islam, that all the guidelines now are disrecommending static parameters, are going with the dynamic parameters? Yes or no?
Yes.
Perfect. That's it. Okay, so نسيبة.
انا اعتقد ان في حاجه اسمها الليد ريزنج تيست.
passive leg raising test.
ايوه passive leg raising test.
Okay. طيب طارق.
I think we have to change the vasopressors because such high doses without good cardiac function, it will affect the tissue perfusion.
I'm sorry, I didn't get your answer. There was a bit of echo in the line.
Yeah. Hello.
I hear you. There's a bit of echo.
I think the change of vasopressors to other inotropes to affect the cardiac contractility will be better than using vasopressors alone.
So you recommend to more with adrenaline and add something vasopressin?
No. I mean to use other factors affecting cardiac contractility other than noradrenaline.
Give me
we can add Dobutrix.
Dobutamine. Okay.
We can.
Perfect. Okay. Thank you. Zahra, what do you think? Did you attend the scenario with us from the beginning? Zahra, do you hear me? Okay, so sorry, Zahra, I will continue with you later on, but I need to continue with the case scenario. So I did an echocardiography to this patient. It showed hyperdynamic left ventricle, small right ventricle, no renal wall motion abnormality, no valvular heart disease because this patient was not known to be any cardiac any before. He had a good systolic function. He had pseudonormal or grade 2 diastolic dysfunction, and I will show you now in the images how to do that. And there was a stroke volume variation on the left ventricular outflow tract, showed positive fluid responsiveness, and that was accompanied by passive leg raising test, the one Nusayba mentioned. So if you follow me through this one, this is the EA ratio, and I do measure the EA ratio on the mitral inflow. So for who don't use echo at all, it's a simple echo view. I'll show you this view in a second. This is the apical fourth chamber view. Is that clear with you, everybody? Okay, so this is the apical fourth chamber view. How I get this view? I am putting my echo probe. It's a very simple view, just below the apex, at the fifth intercostal space, almost at the mid axillary line, and my pointer at 3 o'clock. So I have at this view the 4 chambers of the heart. It's a mirror image. What is on your right side here is the patient's left side, and what's on your left side here is actually the patient's right side. So left side to your right hand, right side of the heart to your left hand. So this is left ventricle, right ventricle, right atrium, and left atrium. Between left ventricle and left atrium, you will find the mitral valve. I'm putting pulsed wave Doppler, which is just the cursor of my pointer at this one, and I'm pressing on a button on the machine called PW. So my pointer will be here and press a button called PW. So you get the pulsed wave Doppler on mitral inflow. So this represents the flow, the blood flow from the left atrium to the left ventricle. The more stiff the left ventricle, the more changes you will find in this Doppler flow. Okay, so let's back to our presentation. Okay, so here this is the mitral inflow, and this is E-A ratio, or E wave and A wave. And as we said before, E is early diastole and A is atrial contractility or atrial contraction. For this one, I don't know if it's normal or pseudo-normal. So from the same view, I will get tissue Doppler imaging. The difference between this one and this one in the color, this Doppler image measures the blood flow through the valve, while the EA prime measures in tissue Doppler measures tissue velocity. So this measures the blood flow, this measures tissue movement. And this is the E prime and A prime. Just to discriminate from EA, we call that E prime or E dash to A prime. Then I will divide the E by E prime and I will get a figure. This figure is very representative of pulmonary artery occlusion pressure. But simple thinking or simple eyeballing, like what I like all the time, I prefer to go with eyeballing rather than figures. If E is a mirror image of, if E prime is a mirror image of E and still taller than the A prime, that means it's normal. While if the E is shorter than the A primes, that means this is pseudo-normal. I need to stop here for a while to hear from you. Islam, is that point clear?
Yes.
Very good. Musaiba, is the difference between EA and E prime, A prime clear to discriminate between normal and pseudo-normal?
Yes, it's clear now.
Okay, perfect. Tariq, is it clear the difference between EA and E prime, A prime?
Sorry that I have some noise during explanation of this issue about the E prime and A prime.
Okay, I'll just repeat that for you again.
Okay, thank you.
Okay, so E is the early diastole and A is the atrial contraction. Normally this is like 70 and this is 30. If the tissue Doppler image, which is again just a button on the echo machine, is the same, so E longer than A or taller than A, that means it's normal. If you find that the E prime, which is the first wave after systole, so this is systole, atrial contraction, and this is diastole. So the first wave is the E prime. If it is shorter than the A prime, so this is reversed ratio, so this is pseudo-normal. Did you get it now, Tariq?
Yeah, okay, thank you.
Perfect. because that's very important for our understanding. Here, this is another tracing, which is left ventricular outflow tract velocity time integral, which I measure the blood flow on the left ventricular outflow tract, means at the area just below the aortic valve. Okay, so from the 5-chamber view, which is just a change, a minor change for the 4-chamber view I showed you a while ago, and I'm putting again the pulsed wave Doppler on the LVOT here and measuring this one. It is the same idea of stroke volume variation on radial artery, but I'm not measuring in the radial artery here. I am measuring on the LVOT. So the more central you go, the more sensitive and specific and the less affection by systemic vascular resistance change in shock you have. So the more peripheral you go in shock, the less accurate measures you get. So you are getting that on the source, on the left ventricular outflow tract, which is the most accurate point in that point. Okay, so here patient had grade 2 diastolic dysfunction and the patient was a fluid responder. So shall I give fluids now in the term of grade 2 diastolic dysfunction, or I need to treat diastolic dysfunction first? Let's go back to our physiological parameters. So patient now is here. If you give more fluids in a non-compliant left ventricle, that means increase in the pulmonary artery pressure. That means more flooding of the lung and more pulmonary edema. And at this moment, you will just realize your patient is not in need for fluids, and you have confusion between the stroke volume variability and the pulmonary edema you got after 500 mils, because you just have given the fluids in the wrong time. You need to give the fluids, but in the proper timing. That's why in my case, what I did is I stopped the adrenaline. The heart rate was 145, short diastolic time. So diastolic dysfunction or heart failure with a preserved ejection fraction. He had no problem with his systolic functions. So that stopped when I stopped the adrenaline, and I took the same mitral inflow. I found now pseudo-normal is changed to grade 1. That means improvement. We are improving to the left side. So I was here because it was a pseudo-normal. I moved to this one. So there was left ventricular compliance severe affection to mild or normal now. Okay, so in this image I have grade 1 diastolic dysfunction at mitral inflow, and as you see here, E prime is still lower than the A wave because still we have a grade 1 diastolic dysfunction. Okay, so I did stop adrenaline. I did stop adrenaline before giving the fluids. Then I took my measures again, grade 1 diastolic dysfunction, and I repeated stroke volume variation. I found he's still fluid responder, and I did the passive leg raising test. It showed a partial improvement, so more than 10% improvement in cardiac output. That means this is the proper time to give the fluids. See here, I've given some fluids, and because the patient was oozy and his INR and coagulation profile was impaired, I've given him some plasma, and then I repeated my measures. He's still fluid responder. Hemoglobin was 7.5 or 7.8, cannot recall the figure exactly now, so he was in need for some blood. At this moment, I've given again some blood, again after assessment of his fluid responsiveness, and at the end, vasopressors, fluids, blood was cautiously titrated, each of them, to guide the resuscitation parameters. After 8 hours of septic shock management of this patient, this is our patient. Post-extubation, because his lactate was normalized by the morning, patient pH was normal, his fluid status was fine, and now he was extubated off all pressors and inotropes. And have a look here on the mitral inflow. This is normal, and this is the A primes. So this is systole, A prime, which is normal. That means this patient had normal systolic function as a baseline and normal diastolic function as a baseline. He had no cardiac problems. So that was the effect of sepsis and septic shock, plus the effect of my pressures inotropes. So you should know that your septic shock management should be guided with the parameters that you can follow the trend in these parameters. Okay, so take home message from this case presentation or this webinar, that echocardiography guided resuscitation of septic shock helps to successfully titrate inotropes, pressures, fluids according to the dynamic changes, and there is a subsequent change and improvement in the clinical outcome. Heart failure with a preserved ejection fraction is always missed or later discovered when the patient already developed pulmonary edema, because there is no clinical tool to judge it. Echocardiography is a non-invasive Swan-Ganz, or even better, because Swan-Ganz cannot judge by eyeballing. You just see figures which you may tell yourself, I don't trust this figure, or I'm not really happy because the clinical context is a bit different. But in the echo, you can see the heart, you can see the contractility, you can calculate your cardiac output, and if you have the mean blood pressure from the arterial line, you can have an idea about systemic vascular resistance. Are there any challenges? Definitely. Definitely, there is a lot of challenges in the background. Training, continuity of care, because if I do echo and I get a message and I'm delivering this message to you and you don't do echo, you are not convinced with the echocardiographic management of septic shock, there is interruption of management. So you may reverse my plans, or at least you may maintain my plan at a time you should have changed if you do another echo and find that the patient has enough fluids or systolic or diastolic functions are changing. So it's a dynamic process. Limited echocardiographic windows in some patients like morbid obese, high mechanical ventilation settings. So you need just to practice that, and there's still some limitations to use transthoracic echo. But if you have that and you are efficient enough, you can use the transesophageal echo. Complex shock or hemodynamic management, if you can't get a transthoracic echo, is an indication on its own to transesophageal echo. Thanks very much for listening and watching my presentation. At this moment, I will leave you for the questions, and anything unclear, I'm so happy. But we'll go one by one just to prevent any interruption between each other. So Islam, that's your side.
مفيش أسئلة.
So everything is clear from echo point of view.
تمام.
طيب.
احنا بنميز بين
How frequent you use echocardiography and how familiar you are with echo different views?
لا أنا مش بستعمل إيكو. للأسف مش موجود عندنا. بس شفته في القصر العيني كذا مرة الأساتذة بيستعملوه. بس.
Okay, perfect.
إنما إن شاء الله ناوي إن أنا أحاول فيه شوية.
That's fine. Okay. Nusayba, what do you think about this case? Any questions first?
انا بس عندي استفسارين. يعني هي حضرتك شفت بالاي اي ريشيو ان هو مودريت دايستوليك ديسفانكشن. انا كنت عايزه اعرف بس لو البيشنت ده مش على الادرينالين، كان ممكن انا اتصرف ازاي لموقف زي ده؟ يعني لو البيشنت مش على الادرينالين، ولا حضرتك شايف ان الادرينالين هو السبب في انه يبقى مودريت دايستوليك ديسفانكشن؟
تمام. If your patient has diastolic dysfunction grade 1 and your E prime is less than 8, that's fine to give fluids as long as his fluid responsiveness on left ventricular outflow tract velocity time integral is showing more than 10% variability, and positive passive leg raising test. That means he has a grade 1 diastolic dysfunction, but he's a fluid responder, and with passive leg raising test, it's okay to give him more fluids. And I add to that, and there is a paper I'm adding here also in this webinar. I'm adding to that, if you do lung ultrasound and you find that the lungs are not wet, there's no B lines on the base of the lung, so don't bother yourself with the diastolic dysfunction. It's not harmful in this moment. And the beauty of the ultrasound or point of care ultrasound that you can do that measure after 500 or 1 liter and reassess to the point that you stop IV fluids. E prime is an indicator to what's the pulmonary artery pressure, so you know when your patient is fluid responder and it's safe to give him fluids. Fluid responsiveness and safe to give him fluids. The fluid responsiveness is dependent on LVOT, VTI with passive leg raising test. And is it safe or is it causing more pulmonary edema on E prime? Is that answer clear for you?
Yes, clear.
Okay. Any more questions?
Yeah, thank you.
Perfect. Let's go to Tariq. Tariq, what do you think?
Yes, يعني unfortunately I am not familiar with the use of echo distribution, but now I think it is a very interesting tool as a dynamic monitoring of the patient and patient response septic shock, as you discussed for us. Thank you.
Perfect. Okay. So, are you interested? And I'm opening all your mics now. Are you interested to proceed now to learn the basic echocardiography use and how to bring that? So if you have an echo machine or any ultrasound machine, you can start to put your probe on a patient and train yourself without any decision making. Just train yourself, just familiarize yourself with the probe, any ultrasound or echo machine. Are you okay to proceed with the echo views, or you want to stop at this moment?
It's okay, we are not interested.
Islam?
We are interested.
Nusayba?
أيوة طبعا interested.
Tariq?
Let us start, please.
Okay, so
okay.
Now so there's 5 basic views you need to know as point of care ultrasound. The first one, we call it PLAX, parasternal long axis view. As you see, the probe here is towards the right shoulder, just sternum, just near to the sternum, pointing to 11 o'clock. So this is the green dot on the echo probe, or the light of the probe, towards 11 o'clock. What you see in this view is right ventricular outflow tract, because you are cutting the heart from anterior to posterior. Then septum, left ventricle, posterior wall. Left atrium, so this is mitral valve, and this is the aortic valve and ascending aorta. This one will be the descending aorta. How to optimize the view? That needs hands-on really. This view, despite it's very important to us, but this is not the starting point I like to start with, because all my calculations are coming from the apical 4-chamber view, which is this one. This is the most comprehensive echo view, so you can just get almost everything in the heart from this view, but you still need other views, of course. So if you just familiarize yourself or manage this echo view, whenever you have an echo probe, you did something good yourself. So left ventricle, left atrium, right ventricle, right atrium, mitral valve, tricuspid valve, and this is some of the pulmonary veins. Sorry, pulmonary arteries. Here you can measure, if you change that one to the 5-chamber view, just a bit of tilt towards the head of the probe. So you open the aortic valve, and if you put pulsed wave here, you get the left ventricular outflow tract VTI. And if you put your pulsed wave here, you measure the mitral inflow tract, and you get EA ratio, and you can get EE prime also from this view. So you can get most of your data from this view, but not everything. So if today we know 4-chamber view, parasternal long axis view, that will be enough. I'll just add the parasternal short axis view, and I'm just rotating my probe from 11 to 1 o'clock. The most familiar Mercedes-Benz sign. And what again, on your right side is the left side of the patient. So I'm cutting at the level of the base of the heart at the great vessels, or the origin of great vessels. So this is the aortic valve. What's on my right side is on the left side of the patient. So this is the left atrium here. So this is the right atrium, tricuspid valve, RVOT or right ventricular outflow tract, base of pulmonary artery. This is the pulmonary valve and pulmonary artery. Okay, so you can cut into slices in the heart to get different views in parasternal short axis views to judge the full heart. Okay, is it really beneficial, all of these views? No, not in our level. I mean, point of care ultrasound, you should do the 5 basic views only. What are the 5 basic views? Parasternal long axis, parasternal short axis in 2 levels. Okay, this one I can judge here the end diastolic volume. If the ventricle walls are kissing each other, that means left ventricular end systolic volume is very low, and that gives me the impression that the patient is dehydrated, either true or relative hypovolemia. Okay, but this is normal heart, normal contractility, normal end diastolic, normal end systolic volume, normal RV size. Okay, so parasternal, then apical 4-chamber view, tilt your probe, bring apical 5-chamber view and subcostal view. Those are the basic cardiac echo views. Okay, as I told you, measurements comes after you manage to get familiar with the echo and the views. Okay, now you have some evidence here I like to share with you. This is diastolic dysfunction and mortality in severe sepsis and septic shock that was published in 2012, and they took almost every echo measure and see what's really correlated with mortality and morbidity. And as you see here, E to E prime ratio carries significant change in mortality with those people. So the higher the EE prime and the more the diastolic dysfunction you have, the higher the mortality. And this paper is available if you want to download it from, and it's free paper. Here, this is one of the first people I received training on his hands. Gabriel Vaya and Susanna Price are the authors of this one, and they are members of the WinFocus. So they put this comprehensive technique on echo and how to measure the cardiac output, and I want to stop here. So to measure the cardiac output, you need to calculate left ventricular outflow tract just below the aortic valve, LVOT. You measure that diameter, and then from left ventricular outflow tract in the 5-chamber view, you get LVOT VTI. So you can get here cardiac output of 3.5, and here's 5.8. So you have the cardiac output calculated. You have the mean arterial blood pressure, so you can have an idea what is your systemic vascular resistance like. If you have high mean blood pressure with high cardiac output, so systemic vascular resistance will be normal. If you have low mean blood pressure with high cardiac output, like here, so your systemic vascular resistance is definitely low. And according to that, you can know what you want to do with your patient. Is it increasing his pressures, or increase his inotropes, or just give fluids? Okay, so this one of the most interesting papers, he's discussing the IVC, stroke volume variability. Most of the dynamic parameters are mentioned in this paper by Gabriel Vai and Susanna Price. Here, this is the combination of focused echo or point of care ultrasound on the heart with lung ultrasound to treat heart failure. So diastolic heart failure or systolic heart failure, you can use both point of care ultrasound on the heart and lung, and it's a very successful paper. Actually, it showed very successful management using ultrasound on the heart and lung together. You cannot do that without anything like in the clinical life. Then this is assessment of the pulmonary artery pressure using the E prime, and here there's many techniques to use that one, but I am sticking to the E prime, and this is again systole, and this is the A prime and the A prime. I think you are already familiar with this one now. So from E prime, you can judge how much is the pulmonary artery pressure. I finished at this point, and I'm very open to all of your questions in the moment. I wish I added something to you all. And now, Islam. Right, I muted you. Okay, Islam, what do you think we should do from now to start learning the echo?
محتاجين يبقى في ايكو في يعني او نروح اماكن التريننج فيها ايكو مبدئيا يعني.
Okay, so if you have an echo in your hand tomorrow, what you're going to do with that?
حتى لو في ايكو هشتغل بيه في يعني هتفرج على كل العيانين من زي ما حضرتك قلت من غير decision making.
ممتاز. طيب, so you want to start like a journey now to go behind each view, like step-by-step approach, so you know without practicing, or you feel that's like waste of time?
لا, البراكتس هو الأساس.
Okay, good. So, Nusayba, what do you think? How you can improve yourself now?
يعني هو طبعا زي ما الدكتور اسلام قال لازم يبقى فيه متوفر ايكو. احنا عندنا في جامعه طنطا متوفر ايكو وناس عندنا كتير بدات تستخدمه. وشايفه برضو ان اللانج الترا سونوجرافي برضو مهم قوي. يعني اعتقد ان هو يعني لازم نبدا بيه وبعدين نكمل بالايكو يعني. وطبعا اندر سوبرفيجن بصراحه. يعني انا بحس اصلا يعني استخدمت الايكو شويه بصراحه، ما كنتش متمرسه فيه قوي، بس يعني كان في ناس عندنا فاهمه فيه، فلما كانوا يعني بيبقوا واقفين معايا لا امسكي البروب كده، لا كده مش مظبوط، لا اظبطيه. حتى اللي هي الفاميليال بالسونار نفسه، جهاز السونار نفسه، الاختيارات والاوبشنز وكده. فانا اعتقد يعني لازم سوبرفيجن بصراحه.
Perfect. Did you attend any of my courses, دكتور مسيبة؟
لا ما حضرتش، وللاسف انا ما حضرتش لحضرتك الكورسز لان هي تقريبا كان ليها عدد ليميتد يعني. بس ان شاء الله في المستقبل باذن الله هحضر لحضرتك يعني ان شاء الله.
Hopefully this summer I'm doing something also ان شاء الله. Hopefully.
ان شاء الله باذن الله.
طارق.
Yeah.
What do you think? Shall we proceed from now, or it's waste of time?
No, we have to proceed actually, but yani, I'm asking you as regards the theoretical or basic knowledge background before using or practicing the echo. Like theoretical illustration, how to use, and that, how much is it important, and if you have any recommended resources to supply our language, our knowledge about basic background. I mean the theoretical background before the practical.
Okay. Perfect. So I think these 4 papers I left here on the webinar are more than enough to start with. It contains a lot of knowledge, a lot of images, and if you read these 4 papers and you have enough knowledge, I can submit or supplement you with more tools like apps or whatever, but I think that will be enough for the moment. That's 4 papers because it gives you a broad idea, very broad idea about everything in the echo.
Okay, thank you.
Thanks so much. Thanks for attending this webinar, and 25 registered, 4 minus 1 attended. There's 1 withdrawn in the middle. So I will push towards more candidates maybe the next week, or I will put this webinar on my YouTube channel, and let's see from then what's going to happen. Thanks for attendance. Thanks so much, and hope to see you soon. Thank you. And I'm quitting the webinar now.